Stress, but and yet effective. Because all that okay, you don't have to be distracted. Yeah, we go face here. No, but it's that's such a brand, it's not inside. Oh, there was no being, we come from here, we said, oh, show me, it's something from there. Se ele foi ali for 30 minutes, eu não sei, essa não é minha oh, mídia só para frente na hora de sábado. Nem para tentar dizer. Eu gostaria de novas pessoas. Isso mesmo, agora que eu acho que acho não voltou muito bom. O filho do comedor. Eu amo ele como ele também. Yeah. Eu digo cara. Ele escreveu, essa é bem melhor. Mas escreveu eu vou na bem, canto com a eu não vou dizer, né? Que tá. Vamos dar seguinte. Não vai dar para dele, quando ele dá na feira,
Okay, good evening, everybody. Please don't know how to apologize, but I'm very, very sorry. Since morning, I don't have so much patience for this evening. We have so many. I can't just leave them. Maybe at the end of the class, we may discuss maybe to change the time to 7. If that should be okay. So let's look at 17, specimen collection. I think many of us are familiar with this already. Those of you that work in the hospital must have at least collected samples from patients. And if you have done a patient one time or the other, you must have given your sample to doctors or to lab scientists. So before doctors can know what is wrong with the patient, there are 3 things they usually do.
That's pretty small.
Oh, really? Class fail. I think you have cases, right? Okay. It's okay. Yeah, thank you. It's okay. Yeah, it's okay.
One doctor that you do. They will need to see what to do.
Okay.
No. Yeah.
Okay, him, right? Yeah. Because I'm surprised. That's very funny. I think we should skip the chapter then. All right. So there are 3 things doctors usually do. First of all is history taking. All right. They get the patient history. Right. They ask the patient some questions person will tell them how they feel. The next thing they will do is examination, all right? If they want to confirm the information that the patient gave them by examining the patient. Then the last thing they will do before they will arrive at conclusion is investigation or testing. All right. For instance, now, if someone has cough, because the cough has been there for a long time, person coughs out blood and all that. First, they will take the person's history, they will do examination by listening to the person's chest, and then they will want to take the person's sputum, all right, to check, possibly to know what is the cause. So for them to do investigation or to do tests, they need to collect something from the patient. And what they collect from the patient is called what? Specimen. All right. There are different specimens that can be gotten from the patient. One is blood. Second is spinal fluid. This is another. Someone has meningitis. They want to know what is wrong with the brain. Or someone has stroke, or has blood in the brain, and they want to check. They will collect the person's spinal fluid. Another thing again is urine. Another one is what? Sputum. Another one is what? Feces. Is there another one? Yeah, I think these are the major spaces. Right? It is only doctors that has the right to collect blood from patients. Doctors and nurses as well as phlebotomists and lab scientists. Also, it is only doctors that also have the right, not all doctors, some doctors that can collect spinal fluid from the patient. But urine, sputum, feces, or stool can be collected by a nurse, a nurse assistant, and sometimes you can ask the patient to collect. So that's why it's a specimen. So our discussion here will be how to collect urine, stool, as well as sputum specimen. So these are the guidelines whenever you have to collect specimen from a patient. One is you have to be very accurate, how to follow the instruction as given by the doctor. For instance, if they want to check a patient fasting blood glucose, what time do you check fasting blood sugar? If someone has diabetes and they want to check the person's fasting blood sugar, what time do you think is the ideal time to collect the patient's specimen? Okay. What time in the morning? Something is wrong. Use the first step. Why they keep using the like this? It's not. Okay, so Carita, what time in the morning? 10 a.m., 5 a.m., 4 a.m., 6 a.m., 7 a.m., 8 a.m.
Like 6.
Oh. The class, we have to hold it and stay there. So I'll be sure that you're working. I don't like this class. I'm not used to this class. I think there's special connection. So, what time?
Like 6 to 8.
6 to 8. Okay. Anna, do you agree? Why? What if you wake up, because you wake up late and decide to collect, you decide to pay the patient fasting blood glucose by 10 a.m. You think what you get to be accurate?
There is no, the patient has not eaten.
I've got it in, yes.
Yes,
Mhm.
so.
It doesn't wake up late. I decide to check it by 10 or 11. Do you think it will still be fasting blood glucose? You have to check. I think it should. Okay. Okay, so fasting. You see, the name is open, fasting blood glucose, otherwise called FPS or FPG. So what it means that the patient has to fast over the night. All right? For how long? 8 to 10 hours over the night. So if it's 8 to 10 hours, let us know that the person's last meal or the person took his dinner by 10 p.m. All right? You start counting from this 10 p.m. When will you get 8 hours? And when will you get 10 hours? If you start counting from this 10 p.m., when will you get 8 hours fasting? And what time will you get 10 hours fasting? So let's start. 10 p.m., 11, 12, 1, 3, 4, 5, 6. So by 6 a.m., you already have 8 hours. So if you check the person's blood glucose by 6, what you get will be okay. So 9, no, no, 7, 8. That will give you what? 10 hours. So if you are checking it, if you check between 6 to 8 a.m., that will give you 8 to 10 hours fasting. So the ideal time to check fasting blood sugar is what? Between 6 a.m. to 8 a.m. If you check it, let us know you check it by 10 a.m. It must, some people might still consider it. It is not, most places will tell you come very early, 6 to 8, because they want to achieve this duration of fasting. So what that means is when you're collecting a sample, you have to be very accurate. All right. Any mistake, either in the timing or the way you compare the sample, can affect the results. The other thing again is to fill out the label carefully. If you see almost every specimen container, it has there's a place where you label a patient. Okay. So you look at the body, you see the patient, the information about the patient. All right. You have the name, not the bed number or the number of the patient. This is and almost all specimen have where you label of where you put patient name and other information just for identification. So before you put specimen inside, the first thing to do is to label it, all right, so that you will not mix it up. And most times again, if you work in the lab, but if you put focus, okay, thank you. You see, you may have many patients lying down. Okay, so many patients urinate into the bottle and their names are not on it. It's possible you can mix it up and you end up giving false results to the wrong patient. So you have to fill out the label carefully. Sometimes in hospital, you have to use the patient bracelet. The information on the bracelet is what you fill it to. The more times again, You already have the patient's folder. You can transfer the information to this place. Another thing, you have to follow medical and sepsis guidelines and standard precautions. Most specimens carry microorganisms. All right, so if you touch them with your bare hand and use it either to eat or to touch your face, you will likely come down with infection. You see, it's very important to be very cautious when handling patients. The truth is that we Africans, our system, all right, is not used to some of the diseases. But if you got a hard cough in your country, right? But that cough you had in your country is different from the type of cough that they have in India, Nepal, and all that. When I had this cough I have now, I don't think I've ever had it. It looks simple, but the type of fever I had, I never had such fever. So just a normal cough. To them, all my patients that had the same cough, after 2-3 days, they're okay. But for me, because my system is not used to it, all right, and from that, so that taught me a lot of lessons. That look, if I'm to abide by standard precaution, wear my face mask, washing my hands, it's not just for the patient, not for the system, it's just for myself. When taking a specimen for a patient, you have to abide by the standard precaution, wear your gloves, assist the patient, store specimens properly. There is fridge, there's hospital fridge. I don't know how many of us have seen hospital fridge. Here, if you see hospital fridge here, it looks very small, it may not be very big. Normal fridge may be around, if you want to buy normal fridge, just take normal small desk. May buy it around 400. The hospital fridge on the same size, if you want to buy it around 3,000. Yes, around 3,000. Fairly is not new one, all right, because it has a where you can use to control the temperature, regulate the temperature of the specimen that is stored in there. So most specimens are stored in the fridge, the hospital fridge, and not the store. For specimen, you don't have to store them, you have to take them to the lab immediately. For instance, spinal fluid. If you are to check a patient's spinal fluid, you must take it to lab immediately within minutes of collection. You don't keep it. If you keep it for some time, you change the constraint. If you check it in the lab, it will give you false results. Because one specimen can be stored, some have to be taken to lab immediately. 2 specimens should also be taken to lab when it is warm. All right, you cannot store it. But some other specimen can be kept for later use. And then, so when you come to urine specimen, there are 3 types of urine specimen. The first one is what? Routine urine specimen. Routine urine specimen, which it's the routine test. You see, anytime you go to hospital, part of the test they do for you is the urine test, right? Which is urinalysis. If they are to collect the specimen from a patient, there is no special precaution because they are not afraid of contamination. When they are doing the test, they are not looking out for the presence of microorganisms. So they are not so particular about contamination. So they will just give the person the specimen container and ask the person to be related to it. All right. They will not tell the person urinate half. Urinate half into a water closet, urinate remaining half into air or something. No, there's no special precaution. It's just routine. They are looking for the chemical constants in the urine, not presence of microorganisms. So, for a urine specimen, it can help them to look out for if a patient has diabetes, all right, they can look for the presence of glucose in the urine. If they see glucose in the urine, it is a sign that the patient is diabetic. They see blood in the urine, it can be a sign that this patient has either acute kidney injury, problem in the bladder, or whatever. There are many other things they check But now let us know a patient has urinary tract infection. A patient has something like urinary tract infection, or a patient has STI, right? And they want to identify the microbe responsible for the urinary tract infection. This time around, they will not do routine urine tests, but they will not use routine urine space. What will they use? They will use what? Mid-3. All right, otherwise called clean catch. Clean catch is now they don't want the urine to be contaminated. All right, so there are precautions. There are some instructions that they will give to the patient. What are those instructions? One is to tell the patient where you want to urinate. The first part of urine, right, should be either into a urinal, all right, or into a water closet, into toilet. Then the mid parts, all right, will be collected in this specimen. Then the last part will be empty somewhere else. The reason why they want to do that, the first part will help to wash the urethra, all right, you have to clean the area. The mid part, all right, is assumed to be free of contamination, right, to contain the actual microbes that are responsible for the urinary tract infection. Then the last part may contain debris, all right, and other things in the bladder if they don't want to collect. So when it comes to urine specimen containers, there are different types of specimen containers. This one is what? Universal container. Universal. You can use it to collect urine. You can also use it to collect sputum. Also use it to collect stool. That's why it is called universal. There's no chemical inside it. That's why you can use it to collect many specimens. But some urine container may have boric acid, may have other chemicals. Then the specimen containers for blood, depending on the test, the blood test may have anticoagulants, so other things to that the blood pressure and other. So when you get a specimen container, it's not advisable to rinse it. Let us assume it falls down now, pick it up and rinse it. If you rinse it, that container there may be a chemical. By the time you rinse it, you remove the chemical. That's difficult. But this type of container, important container, they don't have chemical. Then the last type of urine test is what? 24-hour urine specimen. All right. When do you collect this type of specimen from a patient? You can see children that have the Fuchs syndrome. I've seen a child with the Fuchs syndrome. The Fuchs syndrome, who has seen? Rita? Have you seen children with the Fuchs syndrome? Hannah? Okay. Let's see this child. Swollen face, swollen abdomen. You can see the face by swollen, where is swollen. Take this child's legs, that legs is swollen as well. Likely see this when you go to Central pediatric hospitals. So this child likely has nephrotic syndrome. What is nephrotic syndrome? Nephrotic syndrome is a kidney problem. You see, in the kidney, if you remember when we discussed the right system, your kidney has something that looks like a filter. Your blood will carry waste products and other things in the blood, the kidney. Then around the kidney, there is a filter here. Filter here. And those filters are very tiny. They can only allow waste products pass through them. They do not allow protein, all right, red blood cells, other things in the body to pass through. But for children that has what happens is that this filter here or these pores are wide. The filter is not tiny, but rather they have wide pores. This place is very wide. This place is very wide. This place is very wide. So what happens is that when the blood comes to the kidney, all right, waste products in the blood will pass through, right? Then the protein in their blood will also pass through this. So when the child will urinate both protein together with waste products. All right, so because the child urinates protein, that's why the child have sterilized body swelling. So the specimen they want to collect is 24-hour urine specimen. We want to collect all the urine that the child needs in 4 hours. Right? They will collect all the urine and they will change the amount of protein in that urine. Right? When they change the amount of protein in the urine, and the urine is up, the protein in it is up to 2 grams. Right? It's a sign or it's one of the evidence that the child has. So how do you collect this power urine specimen? How do they collect it? First, they start at specific time in the day. Start by 8 a.m. So if they start by 8 a.m., you tell the person to empty his or her bladder. All right? The person empty his or her bladder. You then start from that time. Anytime the person requests, the person will be asked to, if the person is on catheter, collect the urine from the catheter and put it into a designated jar or into a designated color. Every time the person is pressing, you collect the urine. You keep collecting the urine till the same time the following day. Okay, you then take it to the lab. The lab scientist will then check the amount of or other things they want to look at. So that is 24-hour urine specimen. Then the next one here is stool. All right, so if a patient has maybe gastroenteritis or has something in the intestine, they want to look at, they want to check what is going on. They want to use the patient's stool. All right, so what are things they can look at? Kidney blood, presence of kidney blood. Now, patient, let us the patient control, especially elderly patient. So when they check the patient hemoglobin PCV, it's called a patient PCV is very low. They may check it around, yes, they don't know what is the cause. Why the patient PCV is going down. It is likely that the patient did either or maybe somewhere from the stomach, intestine. But the person's stool may not be bloody. Right? So if we want to correct the patient's check the presence of kidney blood. Another thing again is, remember, I think we talked about sometimes, when the patient's stool is black, right? Black and slippery or slimy, what will you suspect? Take a patient therapy, or a patient complains, you are looking, my stool is black. Anytime I defecate, it's got my stool is very black, very slippery. What will come to your mind? Change your your client diaper, take it in the morning. I discovered that your client's stool is cup. You change it again in the afternoon, very, very dark and slimy. What will come to mind? Ellie? Johanna? I think we talked about it before.
It means the message I problem from the stomach.
Okay. Which problem in the stomach? I don't know. That's why I'm asking.
From the small intestine. Because blood is protein. So when you get there, it becomes blood. But if it is red, if there is no enzyme digestion, then that's why it's red.
Okay, gifts. What do you think? No, I'm not the one that gave you cough.
Sorry?
I'm the one that gave you cough. Hey. Okay. Yes, you have this. Maybe that's why it's my first time. So give. Okay. Give. What do you think? You change your patient diaper and saw that the patient diaper, the patient's food is black. What will come to your mind? All those suspect. Every time you change the patient's food is very black. Will you be worried? Yes. Okay. Rita. Rita, what do you think? Bleeding? Yes. From where? Okay, Gabriel. Yeah. Okay, what will you suspect? What will come to your mind? Yeah, she has an idea. She also have an idea. I think it's the explanation that, but I think she did go in the explanation. All right, so if a patient is bleeding, all right, and the blood is coming from the person's stomach, okay, you don't see the frank red blood in the person's stool. Rather, the person's stool will be black. Why? Why will it be black? Just as she said, the blood is coming from stomach acid, all right, and enzymes in the stomach will act on the blood, all right, and they will change the color of the blood from red to black, okay, and that patient's stool is black. It's called melena stool. Melena. M-E, melena stool. All right, let me see if I can get a picture. Melena stool. You can see something like this. Like charcoal. There are many things that could cause it. One, first of all, you have to change the patient diet first. I also change the patient medication. Make sure that it's not the patient medication, patient diet are responsible for it. So I change the diet and cover that the diet is not responsible for it. Patient is not on the medication that could change the colors with this. All right. Next thing is to suspect bleeding, especially if the patient has ulcer, the patient is elderly, is at risk of stomach cancer, or the patient has been taking an analgesic for a very long time. All right, that could cause ulcer. You should also suspect this. So when doctor sees this, and they want to confirm if this is caused by blood or just caused by medication or whatever, they will collect the patient's stool specimen and take it to lab to check if this is blood, something different. But if the patient's stool has frank or the patient's stool is red, all right, it means the patient is bleeding when the blood is coming from either large intestine, either from the patient rectum, from the patient anus. But if it is black, it is coming from somewhere higher up. All right, so other thing again they can look out for in the patient blood, patient's stool are pathogens, parasites, all right, and fat deposits. For instance, the patient has cancer of the pancreas, the patient has gallstone or bile duct stool, that is stone in his bile ducts. A patient has stone in his gallbladder. Okay, if you remember what we said, that for you to digest fats, you need bile, right? You cannot digest fats without bile. So if this is the person's gallbladder, all right, and this is the ducts, so the bile is formed here. Then from here, the bile will flow from here through this duct, all right, into the person's intestine. So if the patient has stone in his gallbladder on his bile duct, and that stone is here, what do you think will happen? The bile will not be able to flow from here to the person's stomach. And when the person eats food that contains fats, fried chicken or something, that person will not be able to digest the fats that the food. And that fat will come out of the person's stool. All right, so doctor can collect the patient's stool to check or to look to see if the patient's stool contains fats. If there's fats in the stool, it means something is wrong somewhere here. Can that be cancer of the pancreas that might be blocking this place? Can be stool somewhere here. So there are many things they can look out for in the patient's stool. Also, those people that have what is it called again? Lactose intolerance. I don't know if you are familiar with lactose intolerance. They can also collect the patients to check to look for the presence of glucose or lactose in the stool of the patient. There are other tips. So for stool specimen, this can be used to collect stool specimen. It has spatula. All right, you can use it to scoop the stool into this place. You can also use it to collect sputum. Okay, and ideally there should be somewhere here where you write the patient name, other information about the patient. The next is sputum. What is the difference between sputum and saliva? When you see sputum and see saliva, how do you know the difference? Because you can tell the patient, you may want to collect the patient's sputum and give the patient specimen container. Then we just spit into this. All right, you need to check and be sure that what is here is not saliva. If it's saliva, it will not give you what you want. You need to confirm that it's sputum before you go. So, what's the difference between sputum and saliva? Heavy? Okay, yellowish. Okay, is it always yellow?
It depends on the person.
On the problem that the person has. Okay, but one is the color. All right, the color can be yellow. Okay, it can be rust colored, just like when I explain something in rust color, just like rust, brown, all right? Can have blood, some other things. But it is saliva. Saliva is whitish and sometimes colorless. What else again? How I do differentiate sputum from saliva?
Saliva is liquid.
Is liquid?
Yes.
Okay, and sputum is solid?
It's very thick.
Business.
Yeah, the consistency. One sputum, saliva is thin. All right. When sputum is thick, saliva is thin, clear. When sputum is thick. And that thing again, sometimes sputum can although. All right. So saliva or split is thin, clear looking produce of salivary glands. While sputum is coughed up from either from bronchus or from the person's lung. There are many things that can be looked that can doctors they want to check for the presence of blood. All right, person has tuberculosis, person has cancer. They want to check if there's blood between microorganisms or abnormal cells for those that have cancer or those that have lung cancer. And then the best time is just as said there, the best time to collect sputum specimen is in the morning. Because over the night, while the person was lying on the bed, all right, sputum that formed for the patient's lung will accumulate somewhere up here. And to be easier for the person to cough it up, all right, than when you want to collect it in the afternoon or the evening, when the person has walked around. Uh, uh, okay, I think I've come to the end of this chapter. This chapter is really short. The next chapter now is chapter 18. I think you are getting ready for exam, right? Because this is your class, the fastest class ever. So we are going now. There's not the right in the next 2 weeks. Next 2 weeks, possibly.
Next 2 weeks.
Yeah.
Next 2 weeks.
Yeah, you may just have about 2-3 classes now. I wish you have your exam course.
Then the area of it, so.
No, it is so dirty. There is nothing.
Not from one method. Exam comes from one method.
Yes, yes, yes.
How many questions?
If you- No, I need to have water. 50 to 100 cases, depending on what management decides. Okay, so let's look at 18. This 18, sometimes I don't usually discuss. We're just talking about teens in the hospital or in home care. And by the time you start working in the facility, routines vary depending on the facility. You work in this hospital, the other do on daily basis is different from what you do in the other hospital. And if you work in very home care, right, what is expected to do for this client is quite different from what is expected to do for another client. All right. And then for clients at home, the major thing you do for them is to help them carry out their activities of daily living. All right. And what are the activities of daily living?
Water.
Need to get what?
Okay.
So what are the activities of daily living?
Laughing. Eating. Mhm.
Yeah.
Yeah, that's what I'm going for. Meu pai dele existia, deixa eu ver. É claro, meu pai ia para a frente, ele vai me pensar. Oh, I think there is something not made better. And then you crack and break. Não, eu pensar em uma semana, foi meio dizer aqui. This was when you journey, as I was when you every week. Once a week, once a year, one kilo before that. So now what's in a hard that so nothing so by you. Yeah, look well, that was yes. It is like what? And I mean, you can move. I'm good. And that's actually a very close. Intermediate book no. This patient.
So, can you start with the part times?
Yeah.
Okay, so.
Toilet and
Elimination.
Elimination. Yeah, toilet shaving,
Oral hygiene,
oral hygiene,
eating,
yes, feeding, eating. Which one? Sorry, that's fasting.
resting.
Oh, the resting. Yeah, you don't need to help someone to, anyway, it is part of it actually. So if person find difficult, sorry, exercise. Anyway, how many did you do exercise today? Yes,
Yeah.
every day. How about you?
Yeah.
Did you exercise today?
It's not like to sell it to walking.
No, I mean just did you bring out time for exercise?
So
Okay, so it's not everybody that do exercise every day. All right, so it's not really part of it, so it's just an addition to what someone can do in a day. All right, so when we talk about so there are those routines, normal routines, right? So if a patient is in the hospital and the person cannot do anything, all right, as a nurse assistant, or the care prepare them to do those basic routines. So what you do for one patient is different from what you do for that patient. That depends on how ambulant or how strong the patient is. I think I gave you this example. There was this nurse that was taking care of one of the clients, and the client had I think the client was around 90 years. He was doubly incontinent. The client is very heavy, very big. And then the client cannot anyway, she can come out of bed and go to bathroom and all that. But the client depended on her for everything. When she go to work in the morning, she will stay up from that morning till night. Not only that, the client will also bite. Sometimes the client will hit her, will bite her. Sometimes the bite, yes.
the old
The old woman, yes, she had dementia. And also the client's children, they were not helping matters. And they even want her to do almost everything in the house. How much? She takes salary because it is the same agency that pay. Yes. So when after some time he decided to change. All right. Then they then come to find out that particular client, they used to nurses, most nurses, they just spend sometimes some of them stay 2 weeks after to request for change. So two of them 1 month, 2 months. But she was able to stay with her for 2 months. Then they later transferred her to another client. This other client will not even want her to do anything. The only thing she will do is just to give her her medication, help her to do her normal daily exercise. That is all. You don't have to go and sleep. So what you do depends on the patient. It also depends on the society. And also, another thing again is most clients they have their schedule. All right, what we do at this time. Wake up in the morning, when you wake up by 6 a.m., what do you do? By 8 a.m., what do you do? By 11 a.m. For this other particular client, by 8 a.m., the first 6 a.m., so she wakes up 7. By 7 a.m., the first thing they will do is, they first of all wake up, when she wake up, they will take her to restroom. No, first of all, she's already on diaper. So they will first of all change her diaper, brush her teeth, and then what else again? You see, for Hammer home care, they usually give a small board, just a board like this. Like that small board, they will keep it in the patient's room. All right. And then on the board, the patient schedule will be on it. So time, this is what you do at this time. So time, what you do at this time. So time, what you do at this time. So time, what you do at this time. If you don't have that schedule, most times the nurse supervisor usually go on supervision. But when they come on supervision, first of all, you need to look at that schedule. Also, sometimes there's a place again where you have to, if there's an incident, you also have to note it that form in addition to other documentation. You have to. So I think for this patient, the morning is when they do just normal hygiene, brushing, changing her diaper, bathing her, and then taking her break, giving her breakfast. Around 11, what they do around 11 is range of motion exercise while she's on bed. Then I think around that morning again, they give her medication, check her inputs and outputs over the night. And then afternoon again, when they give her medication, check her inputs in the morning and output in the morning again. And then again, evening. So they just have their schedule. So every client have their schedule. When they do this, when they do this, and when they do this. So, but AM care is what you do in the morning, while PM care is what you do in the evening. All right. So when you come to AM care, the purpose of AM care is to get the patient ready for the day. All right, and also to get him or her ready for breakfast. And what are the normal routines or the expected routines? This can vary depending on the client. One is for those that are diaper, you have to check the diaper and change it. Those that are not on diaper, those that are continent, the first thing to do is to help them to empty their bowel, to empty their bladder, either taking them to restroom or giving them bedpan or urinal bed on bed. Then the next thing to do again is checking them. But before you check vital signs, you must have help them to brush their teeth. If the person is dependent on you, may also have to do your bed care, your bed baths. But the person can go to restroom, the person will have to can go to bathroom and help you take shower. When you come back, you take your vital signs, check your input and output charts. For those normal home care nurses, they have their phone, their file. In that file, we have the separate file for vital sign. Because I think by the time we discuss our vital sign, I'll bring those forms. We also have the other form for input and output. We check the patient's diaper, how well the patient's diaper is. Most times, normally, the other thing to do is to weigh the diaper, how heavy the diaper is, determine the amount of urine, all right, that the patient made over the night, all right. And so it is estimated that 1 gram of diaper is equivalent to 1 liter. All right. So most times, but sometimes they don't really weigh. They just say they change 1 diaper. It is that it is very wet or not wet. Just have a way to quantify how wet it is. Then the third form they have is for medication. All right, when you record the medication you give the patient. Then another form again they have is for just progress notes. To record the patient, if there's an incident, what you have done, what you have not done. All right, so you take your routine vital signs. This is just done in the morning. Help the patient wash face, but most times we do bed bath or carry the patient to take. Oral hygiene. We also have to confirm what the patient wants. Does he want to brush his teeth before breakfast or after breakfast? Most people may want to brush before breakfast. But the first thing to do is to know the patient routine or what the patient likes. I remember one of our students that is working with one, she kept complaining that the she doesn't really understand the client, that the client keeps changing her routine. I should do this one this time. Tomorrow the client will say, this is what I want to do as so time. So the advice we gave her was, first of all, study her for 1 week or for 2 weeks. You get to understand what the, no matter how she changes her routine, you must at least be able to know when she normally wants to do this, or want to do that. You can then generate a routine from there. Then another thing again is it is in the morning again you have to change the patient bedding. All right, make the bed, change the patient clothes or outdoor clothes or to his or her preferred clothes. So that is AM care. You do that to get the patient ready for the day and for breakfast. PM care. You now call it PM care, bedtime care, or what? HS care, oral somni. If you see in your question and you see bed care, in option 1, they say PM care is also called A, bed care. Option B, HS care. Which one will you pick? PM care is also called bed care. Option A, option B, HSP. Which one is the correct answer?
HS care.
Okay. Gabriel, you don't get the question. The question is another name for PM care. Option A, bed care. Option B, HS care. HS.
That
Okay. Gabriel? HS care. Why not A? Hannah, what do you think? HS care. Hannah, why? Why? What do you think?
And the HS is a Latin, which means hour of three. And PM is, let's say, PM and the HM is for evening.
How about bed care? Why is it not good? Oh, there's a problem.
During morning, you can think you are going to give this patient bed care. But I think.
So, PM. Yeah, that's the idea here. In case you see it in exam, all right? Bed care and bedtime care are not different things.
Yes.
Bed care is that when you want to bring the patient to bed, you want to strengthen the sheet. But this one bedtime. But what you do when the people are about to go to bed. All right? So if you see the two in option, this is called column. The right option is HS care. What you have is bedtime here. Yeah, not bed. All right. Then other PM care of HS care, almost the same thing. One is you take the patient vital sign again in the evening, give the patient, take the patient input to another over the day. You have to change the patient's diaper and give the patient a fresh diaper over the night, or you have to let the patient to. Another thing again, either you perform the last bed bath or you tell the patient to shower before the night, give the patient his night meal, give the patient his medication, all right? Then position the patient in bed, make the patient bed as well, and position him in bed, all right? Right? So when you position him, for those that have heart failure, you have to help him to have so continent. Then you can leave the patient in. And most places they have their own time where you must finish all this situation. For persons surprised they want to sleep, maybe latest 9 p.m. So that means you have to start all your preparation to get her ready for her nights class. Very early. Alright, and sometimes again, if you have a night care, what finish your clinic, transfer to her to take up. Continue. I think we don't need to waste time here. These topics are not very, just more of talk. So let's look at this one, restorative care rehabilitation. Then the question now is, what's the difference between restorative care and rehabilitation? Restoration and rehabilitation. Are they the same or are they different? Restoration, to restore, to rehabilitate. Context, to restore something, to rehabilitate somebody. To restore, to rehabilitate.
Restore is to bring something
For life.
back to its normal.
The how about rehabilitate?
Rehabilitate is when something, for example, let's say someone is sick. And you are
And I do what I think before you go. To rehabilitate and to restore.
Take an example.
Yes, give an example. Can you use example? Any way you want to use this?
So, let's say, the rehabilitation. Rehabilitation, let's say just with the emotion. Yes, like, for instance, if the person is a drug addict,
Mm.
it means the person has to be able to go to rehabilitation to regain his physical, mind, emotional, and everything back together. But for instance, when someone has an injury, leg injury, maybe the person has surgery, he or she be sent to restorative care, be able to manage and help the person.
also there to reverse the effects. And
Then what is rehabilitation? Maybe I'm confusing you guys, right? Gifts, what do you think? Difference between rehabilitation and restoration. Is there? No, come again. I think you're making sense.
More time.
It takes more time than restoration. Okay. Rita, what do you think?
Rehabilitation is more intensive than
Mm.
restorative. But for the rehabilitation, a lot of this is being considered like psychological, your social, physical, and emotional well-being. Like the example can be they are sent to the rehab.
So how is it different from restoration? More than one person,
One person.
many things. Do you agree?
So what did she say?
You said that you are dealing with more than one thing.
So to be clearly needed.
Okay.
Yeah, like,
Yes,
it's like to maintain the well-being of
okay.
all people.
Restoration.
Yeah.
How about the application?
Rehabilitation is helping the person to adapt to new, yeah.
Let's plan for her. I have an idea. Okay, Gabriel, maybe you may have a better idea. Because what are you paying now? Just
What's the biggest one?
yes.
If I break it, it's not,
Yes.
but if I put it back together, use it on.
Okay, yes.
I will restore it back.
Okay.
Please.
Okay. Sabrina, maybe I'm sorry, you guys may not be not have. You want to make
So
any?
I can do something. I'm going to give examples using
Yes.
rehabilitation is where somebody is taught to learn something new. Like when you, let's say people where you are using drugs and they are helping you
Yes.
to stop drugs and learn how to live without
You have to live without.
using
Yes, yes.
drugs.
Okay.
Yes. And then restoration, I think it's restoration is when you're learning how to live with something you already have.
Okay.
You understand? Not something new. Rehabilitation is something new, and restoration is like helping, like regain, like okay, like when
Okay.
somebody's sick after being sick,
Mm.
regaining
Mm.
the strength,
Yeah.
not something new. You
Okay.
are you getting me?
And we got it. Okay. Well, that's a good attempt. That's right. It aligns with what we are saying. Okay, so let me use this as an
Okay.
example, right? Now to know that restoration is uh there are two groups of therapies. We have physical therapies. We have yeah, sure.
Yeah.
That's the problem. So we have physical therapies or physiotherapies. Because I've heard about them, right?
Yeah.
You either call a physical therapist or you call it what? Physio therapies or physiotherapy. We have this group called occupational therapists. Occupational therapists. Do they do the same thing? Right? These people, they provide their aim is what? Restoration. But this group is what? Rehabilitation. So for instance, now, if I have stroke in this hand, all right, the first thing doctors will do that they will refer me to this good therapy. What will they do? They will start doing some exercise, start massaging the hand. What is their aim? They want to restore the hand so that I'll be able to do these good things, to eat food, to drive, to write, and all that. So their aim is they want to restore this hand to its normal state. That is what restorative care provided by physical therapy. I don't know that this person is a shoemaker that works with the right hand. All right, and the person has had many sessions of physiotherapy for 1 year, and yet that hand is still weak. He cannot do anything with that hand, despite many sessions of physical therapy or restorative care. What is the next thing they will do? Occupational therapists, right, may then start the application. What would they do? They want to train this other hand, this existing hand, all right, to do what the right hand is to do. All right. So the person used to repair shoes with the right hand. Now this hand is weak. We then train this hand, all right, to be able to take over the function of the right hand. That's the application. Or not as we have seen people that don't have hand, yes, they can drive with their legs. It's because of intensive rehabilitation. All right. They were taught on how to use their leg, all right, to perform or to replace the functions of the hand. Okay, that is the basic difference between restorative care and rehabilitation. Okay, I think we'll not waste so much time somewhere here. So there's something called assisted devices. Assisted devices are the things given to patients, all right? Either those that have weakness, all right, or those that have stroke, have injury, all right, so that they'll be able to just to assist them, all right, to be able to carry out that for daily living without much assistance, all right. They want them to be a little bit independent. And because of that, that's why the person has stroke, and yet he wants to drink water by himself. You can't just give him normal complex. You have to give him a job, rough body. But even though the hand is because the body is rough, people can still focus. If you want to give him plates, you cannot give him flat plates. You have to give him plate to him. All right, so that when the person is eating, he will not fall from his plates. You want to give him spoon, you cannot just give him small spoon. You have to give him a thick spoon. But even though the hand is weak, you can hold it. You want to give him toothbrush, you cannot give him normal toothbrush. You have to give him a little toothbrush that help to brush. So these are the assistive devices. Other thing is wheelchair. Now the person cannot walk by himself. You give him the wheelchair. Walker, you know what a walker, right? Crutches. These are different assistive devices. Then for children, for those that cannot talk, all right? If someone cannot talk, how do you communicate with the person? Sign language. You don't have to do sign language. Or you teach the person how to do sign language. You see, sign language. There's a time I wanted to learn sign language, and it's one of the most difficult things ever. There's something called AAC. You can also have it. There are apps. There are AAC apps. AAC is called augmentative, and alternative communication. Alternative communication. All right. Now the person cannot talk with his mouth. So the speech therapists are trained, try to help the person talk. Right? We want to virus. Now the person cannot talk anymore. We have to do an alternative. What is the alternative? You have to give him this device, AAC. AAC, you can have it. You can go to what is it called? You can go to your company, get your app store, Play Store or App Store. Just type AAC. You see 3 AAPs. You can also see the one that you can see paying back. When an ideal AAC comes in the form of iPad. Okay. AAC. It contains almost everything, almost all the words that the person needs. So let us know here you may have section for verbs, you have section for nouns, you have section for preposition and all that. So when the person want to say, I want to eat food, all the person do, that's when you just go to now to pronoun, just let I want to just press it. Right? Then as once you finish pressing, it will speak for you. Just like a voice command. I tell you, I want to eat, then hear what it is. Those of them that have cerebral palsy, that there's cerebral palsy is so bad that they cannot even use their hand to select this. You have low tech, you have mid tech, and have high tech AAC. For the high tech, you don't need to use their hand. It's just like this. It has the screen touch. But this time, it can read the eye movement. So that the person will sit down like this. Look at this place has all the data, all the words. You look at eye. By the time it sees his eye, his pupil, it will highlight. I want, so what it does is just look at it like there'll be a voice command. That will tell you this is what this. Especially children with autism. Children with autism that cannot talk. This is what they use at school. So if you have an autistic child at school, right, that are providing the caregiver of the child, most caregivers are taking that children may have this. Let me get this one. The high-tech one is quite common. Wait, I hope I'm not the one that gave you guys. Wait, so I did not get the call from me, right? Everywhere, right? Okay. If it is me, maybe I'll give you free medication. Okay. Yeah, see you next week. Okay. I want to get high tech. Okay, look at this one. What is the audio noise? Sorry. The audio, what is happening here?
Fully teach what I was supposed to, but I did cover verbs. So today we're going to be looking over the wind slate device, and here on the back is where the power button is, and you would power the device.
So this is this one.
Go. 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 Go.
This girl's brother
So some kids use high-tech AAC devices, which we would count that as like an iPad or a different touch screen that has a communication app downloaded onto it. This is called Touch Chat, and this is one of our students' boards, and he can easily say that he wants to help or to eat or to play. And then we can also talk about people that we see throughout our day, our teachers, our different friends, our students. And we can have describing words. So talking about the weather, talking about our feelings. It's just like how our brain kind of holds all our vocab in it. This is what we would want our students to use to have access to their vocab and be able to communicate. So this is a button, and they produced a vocal speech. So you can record any message on this button, and then when you hit it, the verbal speech will come out, and you can get your message across that way.
Okay, yeah, I think you have this one.
Cole and Carter.
Hi, my name is Jill O'Gorman and my daughter is Elle.
Like to write emails with my Dynavox. Before I had my Dynavox, I used a laptop.
We started out with just Elle was on an IEP. Then we had to submit it to insurance to see if it would be approved.
My teachers helped me with my Dynavox.
We've all had training from Dynavox and again, the assistive technology specialist has.
Hello, my name is Elle.
Does it make it difficult for you if people don't know how you communicate?
Can you see the blue box on the side of the Pathfinder? That's called a click to roll noise, which it means I can't drive my electric chair with using my head switches. If I wanted to turn left, I have to press my left switch until the red light goes on the left arrow. Then I have to hold my right switch to turn left.
Okay, this is the better one I use. So.
Can you tell me how driving a chair is?
I can
Within those lines, they can detect eye movement. I like
go.
what the child needs to do is just to look at one word steadily. Once you look at it steadily, you highlight. Look at this one, but just moving head do not highlight. We have to look at one. Once the position is I1, highlight. I not share this out.
L. E. Lessons. Go. Enter. L.
Okay.
E. Lessons.
Okay. So it's attached to the video, and this is how. This is another example. Right. Just for rehabilitation. Then you have this other thing called prosthesis and orthotics. Prosthetics. All right, so what's the prosthesis? Prosthesis is no. Prosthesis is when someone loses his body part. They use an artificial something to replace it. So if someone hand is cut, what would they do? They can bring an artificial hand and use it to replace the part that's lost. That's prosthesis. Someone has diabetes and they cut the leg, they can give him an artificial, that's what prosthesis. So what is orthotic? Orthotic is that the person did not lose his body part. The only thing that the person has an injury. If someone has injury on this joint, all right, they can use something to support that joint. Or someone has fracture on this hand, they can use something to support the part of the body that is fractured. So that is the use to support an injured part. It's called orthotic. So what is used to replace a lost part is what? Prosthetic. So brace. If someone has an injury on a joint, or someone has dislocation, and they put brace on this joint. That brace is orthotic. Someone has fracture and they put cast. That cast is what? Orthotic. Right? Then someone has someone lost his eye and they use the patient artificial eye. That artificial eye is prosthetic. That's basically. The last thing we look at is bowel and bladder retraining. Then the question now is, why is it called bowel retraining and not bowel training? Why is it called bladder retraining and not bladder training? Why is it called retraining and not training? Or is it there's a mistake here? Rita, so I will not waste time. You have bowel and bladder retraining. They have, yes, go ahead, go ahead. You have a point.
Initially, like before the condition, they had their ladder of power between.
Wait, where did they have the training? Where did they have the training?
Okay, conditions.
Okay. Okay. If the graph, when was the first training? Gabriel, what is it? Why is it called bladder training? Why is it called bladder training? Okay, so let's not waste time so that we can go and break. So this is called bowel and bladder training. It has an idea. See, all of us had bladder training and bowel training, right, from childhood. When you are around 2 years, 3 years, the mother trains you how to do how to hold your fist, right? When you are friends, you don't just get in. Sometimes they have to beat you and all that. So that was the first training. So now you are trained. You already know how to control your fist. Right, but something might have happened along the way. You have stroke, all right, you had injury, all right, and you lost that ability. This time we need to retrain you again. You have to go to the brain again. So that's why it's called bowel and bladder. they do bowel retraining? Most places they don't do this very often. But most people here, especially the other persons, are incontinent. They're already incontinent. They don't want the training may not help much. That's why what they do is just put person just has to be on diaphragm. Alright, so anytime you really want to come out, just enter there. But for young persons, right, someone that's very young, we want to retrain the person to see people again, to hold the living again, or be able to know when he or she is pressed, right, and use press. So, if they are to do retraining, the principle of retraining is you don't want the person to wet his clothes. You want him to know how to do it. So what would you do? First thing is to have a schedule. All right. Let us assume that in a day, the person wets his clothes every 1 hour. Every 1 hour he doing escapes it. Every 1 hour he's doing on himself. All right. So you already know that look, this person's incontinence episode is every 1 hour. If you leave him on bed every 1 hour, he will definitely store his clothes. So what would they do? They can assign a caregiver a nurse to the person. And what the caregiver nurse will do is come to check on this person every 30 minutes. But every 30 minutes before the incontinence episode, you will check on the person. And then, at that 30 minutes, if the person has not soiled himself, they are not urinated, they are not defecated, they may want to stimulate him to empty his bowel and bladder at that 30 minutes. So as to preempt incontinence in the next 1 hour. So we will come to the person and we will give the person, we will give him urine and ask him to urinate. That time this is not pressed yet. So they will give him pepper and ask him to defecate. And most times, if the person is not feeling pressed, they will give him just water to drink. The idea that when the person drinks water, it will spread urine. The little urine in the bladder, the person will pass it out. That can help to prevent incontinence episode in the next 1 hour. And sometimes again, they may even have to press this place so as to simulate urination. Another thing they do again to prevent incontinence episode is anytime the children eats, takes medication or drink water, what will they do? They will definitely give you, after about 10 minutes or 15 minutes, will give you urine or something to empty his bladder. In most places, they don't practice. Here, almost elderly people, they are on diet. It is that the person has double incontinence, most of them has double incontinence. So, bowel and bladder training is not really practiced as much. Then, fecal impulsion is another thing again that is common among elderly persons. Because they don't move around, all right, there are two reasons why they have fecal impulsion. One is they stay in one place. Because they don't move around, the intestinal muscles, all right, are not active. Because the intestinal muscles are not active, if they eat food, that food they eat will just pile up. All right, the feces will not, the feces will be formed, but that feces will not be pushed down to the rectum. Another thing, again, the reason why they have fecal impulsion is because let us assume the person has stroke, or because of old age. You see now, if you are pressed, what will happen? Physics will stimulate, there's a nerve in your hand. All right, so if you have physics around you, that stool will stimulate the nerve. All right, and that nerve will inform your will let you know that look, something is there that they want to use restful. But for them, the nerve is not sensitive. So they may have physics in their rectum and they may not know. So the physics may keep piling up for 1 day, 2 days, 3 days. All right, and over time, that physics may become very hard. And when the physics becomes very hard, there may be a need to help them to remove it. If you don't remove the physics, the patient may not be able to eat. The patient we just have bloated abdomen. So most elderly persons, they are usually on different medications. Take all the clients in their houses. They have, just as I said, they have vitamin D. Usually give it to them to prevent osteoporosis. Secondly, they are usually on constipation medication. All right, you know that they have lactulose as part of the daily medication. They are given that to just to soften the stool. All right, so that in case they cannot sense or they cannot know that there is stool around there, because the stool is already watery, it just come out by itself. But most times, even they may be on lactulose, yes, fecal immersion may still occur. In that case, there may be a need again to put either put suppository, Nicholas suppository, just put it into the rectum to soften the surrounding, or to do manual disinfection. Manual disinfection is you remove the hand with your hand. Most times, they may take lactulose because the physics is already hard. You will take the lactose, but the lactose may not be effective. You may put your Nicholas may not also be effective. Right? Because sometimes the physics can be as hard as stone. So there may be a need to use your hand to do disinfection. All right. If you don't remove it, that patient will not be able to eat food. The manual disinfection, you have to do double glove. All right. You also have to use gel. All right. So don't just put your hand inside the patient's rectum. And most times, because they are prophylactic, because they are giving lactulose, they take it every time. It doesn't allow the physics to. It doesn't allow fecal infection to occur. But if it occurs, then we may need to do this infection. But yes, go ahead.
I think,
For the child, and then yes.
then there was this constipation. But now they use what is fast.
What is of bronze?
Fast. So
Oh, yes.
inside from the annex, then after a few minutes. So what's the business?
No, it's here. If there's some children that have there's something called H-bone disease. You can also have some hospital clients. One here is the engagement, you should open your mind to anything. There are so many diseases, especially around you. There's some children that have this type of disease that this is the intestine. The intestine is okay. But towards the rectum, the intestine will just the rectum will be very, very narrow. So narrow. But I want to put physics will form here. Because the rectum is very narrow, the anus is very narrow, that physics will not be able to come out. As well as children, they may not even open their bowel for 2, 3, 4, 5 days. And for them to open bowel, they will be need to do DRE, do digital representation. All right. Then sometimes again, doing DRE for them may not really help. We have to use soap just as they need, or we have to use enema solution. The idea to use is not soap. The idea to use enema solution. Enema solution comes in a bottle. Just has a pointed tip. All right, that you can push it into the rectum. Squeeze the fluid into the rectum. That fluid will go into here. If some enema solutions are oily, just like oil, some of them are something like soap. All right. So when you push the enema solution into here, it will make the physics, it will lubricate the physics. All right, it will lubricate it, and let us know the physics is already impacted on the wall. Okay, it will help to lubricate it, and that will make it easier to come out. So enema solution, when you push it here, it will help to soften the physics. All right. Also, the same thing is applicable to soap. What soap does is a sort of lubricant. All right, that helps to lubricate the food. Make it difficult. There are many things that there are different animal solutions that have different techniques. How they act. Then the next thing here is range of motion exercises. The different exercises that you can do on your client or your patient. We have passive range of motion exercise. Passive is that the patient does the exercise by himself, just doing the instruction. We do the exercise. No, active. The patient, you give the patient instruction either to bend his hand, to bend his arm. The passive is that you do it for him. Then you then have active assistive. Active assistive is that the patient bends it, but to a point that he cannot bend it further, you then assist him to finish up the process. And when you got to range of motion exercise, there are different movements or different exercises that the patient can make, or at different joints. So you can help your patient to make at different joints. For instance, a patient with stroke, if the patient lies in one place 24/7, all the things will happen, this joint will become stiff. This one will also become stiff. Or once it will become stiff, the hand will become weaker over time because the patient doesn't move the hand. So there may be a need to move the hand for the patient. Since you elder the patient, you have the time when you do exercise for them during the day. Sometimes you can do it maybe after breakfast, or you know they shape it when you work with them. So now looking at this elbow joint, how many movements can you make here on the elbow joints? 3. No, sorry, shoulder joints. Only how many movements? If you are asked to move this joint or to exercise the joint, how many directions will you move it? 3. How many movements can you make on the joint? Okay, I think our time is not that much, so let's push faster. Here, how many movements can you make here? Rita? Yeah. This joint. If I have to exercise the joint for somebody, how will you move it? 3, right? Okay. Yeah, you are getting it, understand. 1 is this. What is this? Flexion, right? Okay. What is this? Back. What is the back? This is flexion. This is what? Extension. Extension. You're extending it to the back. So this is flexion. This is extension. Then come to the center again. This is what? Okay, this is the way, right? Okay, how about this? Yes, the easiest way to remember it is when they thief or when they kidnap, what do? They abduct. All right. So if you take the hand away from the body, this is called abduction. Abduction. If you want to adopt somebody, what do? You bring the person to yourself. All right. So this is abduction. This is adoption. All right. So flexion, extension. So if you are doing It starts from here, from a neutral position, up. You come back to the neutral position, back. That is extension, right? You come back to the neutral position. What is it? Abduction. You come back to the neutral position, abduction. Okay? So how many movements here? 4 movements. So how about here? How many movements can you make here? Elbow joints. How many? Yeah, this one is just 2. Neutral position, flexion, extension, flexion, extension. That is this for you. How about your wrist? How many movements can you make here? 4 movements, right? Okay, what are the movements now? Okay, so what is this? What is this one? This is flexion. What is this one? Extension. Do the same thing. Flexion, extension. Then, coming back to the neutral position now, you can move to this side. You can move to this opposite side. So what do you call this one? Now, neutral position, right? You are moving here. What is this one called? This is called, you see, if you look at your hand, there are 2 bones here. This bone is radius. That's why you have radial artery. This bone is what? Ulnar. Okay? So if you move the hand towards the radius, you call it radial deviation. You are deviating it towards the radius. Radial deviation. To move it towards this ulnar bone, that's what? Ulnar deviation. Okay? So how many movements do you have here? 1, 2, 1, 2. Come back to the center. Here, here. So round 1, 2, here, 4. Then you can do a little rotation. Okay. Then this one again, this. What is this movement? See, this is straight, right? What is this? Remember when we talked about position, supine. What is spine? You are lying on the back. This is supination. Supine. What is prone? You are lying on your face. So this is called supination. Hello? Okay. Okay. This is called what? Pronation. Supination. Pronation. You see, this movement, there's a joint that this movement exercises. This is joint that is between these 2 bones. Moving the hand this way, exercising that joint between the 2 bones. Up exercising the joint. This one exercises the joint. This one exercises this joint. Same thing again, finger movement. Then, on your foot, if you do like this, if you bend person's foot forward, what is it called? Flexion, right? If I bend it down, what is it called? Remember here, this is what? Flexion, right? This is what? Extension. Okay, so let's look at this one. Let's see if we can apply it here. Then you have your patient foot. This way, what is it called? Bend up. Or you bend, this is what? Flexion, right? If you bend down, you call what? Extension. Yeah, but all the things.
This is the extension.
But see, there is no extension. We only have pressure, right? You have inversion and eversion. All right, so look at this now. If this is somebody's foot, this is somebody's foot, this is your foot, your foot. This place is called what? Dozu. Dozu. What's the name? Dozu. Dorsal surface. This is dorsal surface. Then this place is called what? Plantar. You see, you plant your leg. Plantar surface. So if you move the patient's foot towards the dorsal, it is called what? Dorsal flexion. All right. If you move the patient's foot towards the plantar surface, that is called plantar flexion. Then, if you move the patient's foot this way, the patient's foot is turned in. This is what? Inversion. Out. Eversion. All right? Now, what's commonly done with more plantar flexion, flexion, then, how about neck? Another movement of the neck. I know some folks can turn our neck 360 degrees. So how many movements can you make on the neck? Quickly, this is what? Flexion, right? This is what?
Extension.
Extension. This is what? Eh? This is what?
Right, extension.
Okay, so let's do extension. No, flexion, extension, left rotation, right rotation. How about this one? Eh? How about this one?
Left and right. Flexion. Lateral.
Yeah, this is rotation, right? Here, this is flexion. This is another flexion. This is another flexion. This is extension. But this is left flexion. This is right flexion. This is right. No, sorry. Let me get it. This is left rotation. This is what? Left flexion. Right? This is right rotation. This is what? Right flexion. This is what? Extension. This is flexion. Okay. All right. When you are doing any of these movements, you have to be very, very careful. You have to be as gentle as you can. If patient has neck collar on the neck, don't avoid the neck. Don't do exercise on the neck that has collar. All right. If patient has pain on that neck, just have to be very careful. Get a report of supervisor or confirm from doctor whether to do the exercise for this practice. The other thing when you're doing exercise, you have to start doing it in orderly manner. You have to do head neck first, move one side, finish one hand, do the other hand, then move to the leg, and then. If you're doing exercise again, you have to be as gentle as possible. If the patient feels pain, just have to stop. Swelling, don't exercise the joint. If the patient is strong enough, first thing to do is ask the patient, please can you bend this your hand? All right? Let the patient try it first. You see that the patient cannot do it, then go. But if the patient is unconscious, you don't need to. You have to be able to all the movements of the patient. And most times, the therapist need to give the instruction on the movement on the joint to exercise. How many times exercise the joint? how many times you do it in a day, all right? And as for that again, most patients, when they're going for the therapy session, they usually go with the caregiver. You have to see how they feel that they have to complete that. Yeah, that's basically what we need to know here. There's nothing much about that. Yeah, this other chapter, additional patient care procedures. Oh. We'll stop here. So next week, what we have next week, look at this 2020, look at period of relative flow, and then parallel. So if we finish the 3 topics next week, 3 chapters next week, the exam will be up. Hope you are ready, right? The other week coming. After this week, the other week is the exam. So what we do on your exam day is to discuss the last chapter, then the exam. All right, so since we have finished very early, I think we have enough time for level 5. Not rush 5. It's much better. Okay, we'll stop here. Any question from anybody? Isaac, Noah, Agnes, Winnie, Sabrina, Hannah. Any question?
About
No.
occupational therapy, to help someone with cerebral palsy.
Sorry, I didn't hear you, Winnie.
Occupational therapy, does it help someone with cerebral palsy? Where do they do it on cerebral palsy people?
For cerebral palsy, yes. You see, both occupational therapists and physical therapists, they work on people with cerebral palsy, but most times is they help the person to see how the person can live an independent life. All right.
Okay.
It's teaching him
And
how to be on which. Sorry?
And that machine that you've shown, if it is reading someone's mind, can it help someone with cerebral palsy? Because that one has a brain damage. How does it do?
I can't hear you, Grace. Sorry.
The AAC, the machine that I don't know, it's reading someone's mind and reading.
No, the AAC is rehabilitation.
Does it read someone's mind?
No. AAC doesn't read the person's mind. It read the person's eye movement.
Okay, I get it.
You have 3 types. You have low tech, you have mid tech, and high tech. For low tech is the use of paper, picture. Some of them they have a book like this, and in that book they have pictures of different things. So whatever they want to say, if they want to say something, they just point it. You look at it and know what they have in mind. That is low tech. For mid tech is with use of iPad. The person can touch the word. Once he touch it, it will vocalize for him. That is mid tech. But then for high tech is the person just look at the word. That word will highlight and vocalize for him. It doesn't read their mind, just for the person to look at that word steadily. But if I want to say your name, what I will just do is just look at where your name is. All right, and it will highlight, and then it will vocalize for the person. Is it clear?
Yeah. Okay.
So the people that teach them how to use them are the occupational therapists. All right, it's a form of rehabilitation, teaching them how to talk when they cannot talk anymore. Okay, Sabrina, any question?
No, sir.
Anna, any question? Agnes, Isaac, write your name in the chat box and see you next week.
Okay, sir.
Okay. Yeah.